My name is Darryl Hollar. I'm a director in the eHealth department and the IT department at Mount Sinai. It's my pleasure to introduce Eric Rosow from Diamond Health. As a participant and a mentor in the New York Digital Health Accelerator program, we chose to work with Diamond Health not only because of my background in health information exchange, but because of the promise that we saw in their tool to analyze and cleanse complex data coming from disparate source systems. While we understand that the challenge and the scope of dirty data and cleansing that data at the health system level or the Rio level or the state level, it's an enormous project, but we understand we really want to transform that data because we see the value that can come from that. Our pilot that we're working with Diamond Health on, we're taking several thousand CCDs. We're analyzing those CCDs, identifying dirty data, and then we're looking for opportunities to cleanse that data. It's my pleasure to introduce Eric Rosow, the CEO of Diamond Health. Eric has 25 years experience in healthcare technology as an entrepreneur and administrator. Prior to co-founding Diamond Health, Eric founded Premise Corporation and served as chairman and CEO prior to a successful sale to Eclipses, where he served as VP and general manager. Eric also worked at Hartford Healthcare, one of Connecticut's leading health systems, as director of biomedical engineering, and he is the holder of multiple patents and has authored more than 50 academic papers and other publications. Please welcome Eric.
Thank you so much, Darryl, and thank you so much to Maria and Sunny and the Accelerator program for being part of this year's really impressive class. It's a great group and really impressive CEOs, so just want to acknowledge that. So when we talk about what we do, we're a digital health company, and we work with health systems, accountable care organizations, health information exchanges, and health plans, and really help them derive much greater value from their data. And when we think of the data that these organizations have to swim in and navigate, the rhyme of the ancient mariner comes to mind. And I think anyone who's worked in this space, which I suppose many of the people in the room have, can appreciate the challenges taking all this messy, incomplete, and disparate data and turning it into information, knowledge, and wisdom. But this is really hard because healthcare data is inherently complex. For example, there's over 1 million different terms spread across different vocabularies, different ontologies, and at the same time, all these electronic health records are frankly still evolving. And they're not very good at capturing it all, and they're not very good at sharing it, even though interoperability is a very commonly used word. So I wanted to, the big problem is really data overload and dirty data, as Darryl said. And we're big fans on listening to the market and listening to the voice of the customer. And I wanted to share with you a couple quotes that are representative of what we hear every day and why we created this company. A thought leader on interoperability simply said, if you give me a 70-page CCDA, it's probably 68 pages too long for any physician to work with. Or another physician we work with up at Partners in Boston said, if you give me 7 CCDs from my HIE, I'm not going to look at any of them. And more recently, the CEO of a very large HIE right here in the city simply said, our biggest challenge is badly behaving data. So we know as a country, over the past several years, we've spent over $30 billion to adopt electronic health records in both inpatient and ambulatory settings. And yet much of this data still remains fragmented. When we consider a rapidly growing population segment, Medicare, roughly 40% of those patients have 7 or more different chronic conditions. In addition, those patients see 11 or more different care providers across 5 different settings over the course of a year. And when we look at the electronic health record industry in its own right, that too is quite fragmented. And even if you take the top 20 EHRs, including the big guns like Epic and Cerner, you still only aggregate about 70% of the total market share. When we examine this further for those high-cost patients, we can see, as I said, that they see many different care providers in different settings, but the other challenge, particularly in what we refer to as the Wild West of ambulatory, their data can be contained in multiple different silos across multiple different electronic health systems. And the secret sauce of Diameter Health is our ability to unify that data to deduplicate that data, and where necessary, to enrich that data in order to support care transitions, population health, and our own or an array of third-party analytics. So how do we do this, and what do we do? Well, our mission is to really improve the safety as well as the clinical and business outcomes of our clients. And we do this with a core engine circling in the middle we call Fusion. What Fusion does is it can take this multi-source clinical data, it can use its unique algorithms to parse, to deduplicate, to normalize, and to enrich that data to enhance its quality. And the output and benefits of such are to help support a comprehensive patient record, to identify patient populations at risk, to improve the documentation of the data, and to provide certified quality measures. And all of these are done in a completely automated, accurate, and highly actionable manner. So without getting into great detail, the way it works is, as Darryl touched on, any certified electronic health record today has to produce this thing called a CCD, which is a continuity of care document. And we have deep domain expertise in that. In fact, my partner and co-founder was an editor on the standard, which itself is over 1,000 pages long. We refer to this core value add as simply clinical intelligence. And this diagram shows you what sections are contained in the CCD, and without going into all the different segments, it's things like problems, allergies, vital signs, labs, and social history. And the reason we hooked our wagon to this horse is that not only can we work with any certified EHR, but we don't require any custom interfaces or any custom extracts or any data marts or data warehouses. We just get the data in its native form. And unlike claims data, as Robert referred to, we're getting much richer clinical information, and you're not waiting months to get that data. So our analytics are actually actionable while the patient's still in the hospital. So this is what it looks like. When we look at a population, we can take an entire population at a health system, at a hospital, or even across a broader arena, run it through our platform, and then output patients at risk of different conditions, opportunities to increase your documentation and therefore revenue, and stratify them into different cohorts with specific care protocols. So why does all this matter? Well, as I said a moment ago, data quality and data accuracy matter a great deal. And frankly, if you don't get it right, it can be toxic or even deadly. And I'm not expecting anyone to read this. This is an intentional eye test. But what I wanted to show you here was a section of a real-world CCD. And what this does, the section highlighted in yellow, says code number 7982 is displayed as codeine phosphate. But our tool looked at that, and actually code 7982 is not codeine phosphate. Code 7982 in RxNorm is actually penicillin. And that's a real problem, because that can be dangerous. And so we can use our tool to catch things like this that normal HL7 schema and schematron tests won't do. Let me give you two more case studies in the real world. Here's a patient at one of our clients. They presented at the hospital in the ER with congestive heart failure, COPD, chronic kidney disease, and pneumonia. Pretty sick patient. And despite all those presenting conditions, their predicted risk of readmission was only about 25%. What these traditional models don't account for that our model does is the fact that the patient was on over 20 different medications, had abnormal lab tests, had a longer than average length of stay, ended up discharging but to a rehab center, and was a frequent flyer over the past year. And consequently, our algorithm shows that patient not at 25%, but at 70% likelihood to readmit. And sure enough, the patient readmitted. Now this becomes even more powerful when we look at a population. So here's our same client with a year's worth of data stratified according to their risk. And you can see most of the patients fell between 8 and 14%. When we take that same population and run it through the diameter model, we get this. And this is really what you want, because here we're discerning the low-risk patients in the green zone to the 20% that really are constituting over half your readmissions. And that's what you want to do to better allocate resources. One final example, we're really good at using the same data set to identify gaps in clinical documentation and comorbidities. These bar graphs represent the percentage of time that things like congestive heart failure, chronic kidney disease, and diabetes existed as a comorbidity in the patient, but were never documented. And at some of our hospitals, that's over $1 million a year of opportunity. We can drill down on that data. We have highly actionable lists at the patient level with corresponding MSDRG mappings and revenue corresponding. Makes a big difference in the way we can do this to identify patient acuity, better care transitions, and better benchmarking. So finally, the ROI. how can this all add up? Well, even for a relatively small hospital, roughly 30% of patients are missing some form of documentation in terms of the comorbidity. That's not to say they weren't treated for it, they were, but it wasn't documented. And roughly 1 in 6 of those patients would qualify for a higher Medicare payment. The average revenue on that Medicare payment is around $2,500. And even for a 250-bed hospital, that can translate to over $500,000 per year. So we're very proud to be working with a number of leading health systems throughout the region. And I want to do a call out. We're actively in pilots with both Mount Sinai and Rochester Regional Health System. Really excited about the work going on there. We're also very proud of the investor syndicate we've pulled together, and call out to Todd Petrie, who's somewhere here, for nominating us for this program. Both Todd and Connecticut Innovations were both investors in my last company. Great to work with. And I'm also very, very proud of the investor syndicate that we've pulled together of thought leaders throughout the country, one of which is sitting there, Mark Anderson, the former CIO at Yale New Haven, New York Presby, University of Virginia, and Brigham and Women. The list goes long. And then last slide, with that, we've been able to expand our core team, a lot of deep domain knowledge across this team, a lot of thought-leading publications. And on behalf of that whole team, again, I want to thank the New York Digital Health Accelerator for this opportunity. And if anyone's interested in cleaning your data or learning more what we can do for your systems, here's my contact information. Thank you so much.